Rob and I have appropriate hats on here, Paul Jen, because there ain't nothing funny about this paper. So we're just going to be funny right now because you look ridiculous. Let's see what your face. Let's see. Nicely done. This one is called Elder Abuse. It's by Mark Lax, MD. It's in the New England Journal of Medicine. We're going to learn something about it. A very important topic. Not a lot of funny stuff to say about it.
I used this paper my last shift.
Oh, nice. All right. John, teach us.
Change my practice.
This is a really good paper, and it's a good review of a lot of clinically practical things. And just to start off, elder abuse, it's one of those things that's frustrating and difficult, but at the same time so prevalent. Up to, in some surveys, national and local surveys, 1 in 10 to 12 elderly patients who present to the clinical setting are actually victims of elder abuse, which is alarming. Some risk factors that are associated with elder abuse are female more than male if the patient lives in a shared living environment with family or with multiple other people, if they're socially isolated or lack social support, and it's associated with increased rates of death, nursing home, and depression. There are significant consequences for missing elder abuse and not intervening. And to also clarify, I think it's really important. I really like this article because they're highlighting the fact that in cases of elder abuse, it's not like a superhero one and done. You extricate the victim and then you save the day. This is an ongoing team effort, and it can be maddeningly frustrating, especially when you lack resources. But it involves not just the clinician. You're talking about the community at large, not just social services, but law enforcement, legal, community resources. A lot of different people need to be involved in this to solve an ongoing issue.
Big take home from the paper there, because like when you have somebody who's a victim of domestic violence, or you need to get them to a shelter, and that's immediate, and their life is restructured immediately. But the expectation is that doesn't happen here.
Yeah. And so from a clinical standpoint, what clinicians can do, one of the most critical actions is to separate the patient, the elderly patient, from whoever brought them if there's someone who came with them, because you want to make sure you get a good history and physical exam to be able to recognize the red flags that should trigger you to think about getting more resources or getting more people involved. And so from the elder abuse categorization standpoint, there are 5 main categories: physical, psychological, verbal, sexual, financial, and neglect. Financial is emerging as the most common type of elder abuse, at least here in the United States. But we're going to go through each of these categories to recognize some really cool things and interesting things that you can use on your next shift. So on physical exam, there are certainly typical types of patterns and red flags that you want to be aware of. If there's multiple types of healing injuries, you want to be aware of that. But in elderly patients, bruising can happen for no reason, and it doesn't necessarily have to be related to trauma or abuse. But there's certain things that may want to trigger you to think about, something's not quite right. So the location of the bruising on the face or the lateral aspect of the arm, posterior torso, or maybe the wrist and ankles because of restraints, there are things that should kind of like make you take a second and think about it. It's not medical or legally clinching as far as a diagnosis of elder abuse, but it does make you give pause. Some questions you can ask is, do you feel safe at home, or does anyone hurt you at your house? And so you want to be aware of that. Psychological and verbal, signs of intimidation. These are common sense things where you walk into a room and it's like the patient, the elderly patient, is deferring everything to the caregiver or the other person in the room, or the actual other person in the room is yelling and verbally abusing, cursing at the patient. Those are things that you really should be thinking about, that's not right about the interaction. And some questions you can ask are, does your family ever yell or curse at you, or are you prevented from seeing your friends? Sexual, they're the things that we already know. You suspect GU trauma, or if there's sexually transmitted infections or recurrent urinary tract infections. You want to actually do a pelvic exam and see if there's any suspicion for sexual abuse. One interesting thing unique to the elderly population is that if they live in a nursing home, there's higher risk, and you should actually ask the nursing home if there is a hypersexual resident who has dementia, because they are associated with higher risk of sexual abuse. Financial, as we talked about, is probably now more and more common as far as the type of elder abuse goes. In the clinical setting, like for me at first, before I read this article, it seemed like, what can I do? I mean, what am I going to ask? But there are triggers or red flags you should be aware of that are clinically related. So if they're not renewing their medications, they're not compliant because they don't have the money to buy their meds, or they're not following up appointments you're giving them or have been given to them, or if they're in malnutrition because they can't buy food to feed themselves. Questions you can ask is, has money been taken from you without consent? Is someone else handling your finances? To at least open the door into that conversation. And then lastly, with regard to neglect, this is more in our wheelhouse, if you will, because if you see decubitus ulcer, signs of dehydration, malnutrition, poor hygiene, then that should raise your red flags to actually intervene. And the first thing you should do is, and says it multiple times in the papers, assess the patient's capacity for decision-making capabilities. Because especially with elderly patients, we oftentimes aren't attuned to the fact that they may be demented and may not even necessarily have capacity. That changes the management entirely. Also, know your resources that are available to you. A lot of us don't have the luxury of having a case worker or social services available 24 hours a day, 7 days a week. But you should be attuned to what you do have. And there are resources like the National Council on Elder Abuse, the website down here. And as a provider, you can also, as a clinician, you can also try to start the conversation with your institution to start having that interprofessional team developed. And always, of course, report elder abuse if you have mandatory state laws, which is pretty much prevalent in the United States everywhere. So in summary, unfortunately, there's no easy fix for elder abuse. You want to make sure you assess the patient's capacity, separate out the patient from whoever is accompanying them to get a good history and exam, and then really recognize the red flags in order to refer, consult, and educate the patient.
There was a big take home for me also in this paper and how to approach the caregivers if you're suspecting that their abuse, that they could be the ones abusing them, because sometimes they might be hostile, they might be aggressive. So what they say not to do is, here, I'm gonna break the wall here. They say not to do this. What is your major malfunction? No. Tell me what's going on at home. Yes. Chill. Equanimity.
I don't know who actually hired this guy.
On to the next one.